We're talking today about mild traumatic brain injuries, and this is a topic that we're seeing more and more in the media. We're seeing it in the context of sports injuries, the NFL, and the repercussions of what happens to people who suffer injuries to their brain and how they manifest themselves over time in different ways. Now, we've got a lot of fun phrases that we've used historically to describe what happens when you suffer a hit or a blow or some sort of injury to your head. So these were just some of my favorites that I sort of rattled off when I was thinking about traumatic brain injuries. How about this one? Punch drunk. Shaken up on the play. You hear that one a lot, right? That's a great euphemism. Oh, he's just shaken up on the play. Don't worry, he'll shake it off. He's shaken up on the play. She had her bell rung. Saw stars. That's a good one. Had his clock cleaned. So we have, and there's one more, knocked silly. And all of these are phrases that we hear all the time to describe what it is that happens when someone has a blow or injury to their brain. And the reason I think we've always historically used these sort of euphemisms in different terms is because there's nothing we can see about what happened. We're naming it and describing it by what it looks like to us when this happens to the person. They look drunk, silly. They saw stars is how they'll describe it, or they look like they're looking at the stars, right? So we're using words to sort of describe what it is that we can't quantify in other ways. So this is all the different phrases that we use for the injury formerly, with apologies to Prince, the injuries formerly known as concussions. And that's really not the term that we use much anymore because it wasn't as descriptive as what we now call them, which is mild traumatic brain injuries. So we need to talk a little bit about what is that. So here's the official fancy medical definition. A complex pathophysiologic process affecting the brain induced by traumatic biomechanical forces secondary to direct or indirect forces to the head. What does that mean? It means we don't really know what it means, except we know it has to do with the forces secondary to some sort of insult to the head. And it is caused by a blow or a jolt to the head that disrupts the function of the brain. Now, why is that an important part of this definition? We're talking about an insult to the brain that disrupts how the brain itself is working. It is like when everyone have the experience where you drop your phone and it goes black and you go, and you just hope like heck it turns back on. You've given a jolt to an electronic device by a force that has disrupted its usage. And you're hoping that it turns back on and goes back to what it was doing. But you can disrupt anything with a blow because you're interrupting all of the electrical forces that work together to make the object function. That's what happens in a mild traumatic brain injury. We've got a force that is disrupting how the brain works. Leading causes. The leading cause is falls. And in Wisconsin, falls on ice, falls down slippery stairs. It can be caused by falls during activity. There's a spate of injuries caused by people in inflatable sumo suits tipping over and hitting their heads. Kid you not, Google it. So that's an area where a fall, tipping over, causes it. If you think about how it is when we do fall, what's the break when you break this bone in your hand? Used to be called the rollerblading break, and then they got those scooters, those razor scooters, and then they labeled that same break the razor scooter break. It's because when we fall, we put our hands down to catch us. We put our hands down to catch us because we don't want our heads to hit the pavement. If you can break your wrist putting it down to catch yourself in a fall, guess what happens to your head if your wrist doesn't make it in time? That's what's going on with those sort of causes. Sports. Seen it 100 times. You've seen it in football. You're seeing it in soccer when people are heading the ball. You're seeing it, I think, fairly unrecognized in soccer. It's sort of playing possum while football gets all the attention. But you've got children being taught to head a ball. And does that seem like a good idea at the speed and size of that object if what we're trying to do is prevent an interruption of the processes and flow of the brain? Just throwing that out there. Soccer's not the topic today. We're talking about car crashes. And we see a lot of situations where car crashes can cause a jolt to the brain. And that's not necessarily because people aren't wearing their seatbelts. In side curtain airbags still are not mandatory. I don't believe they're mandatory yet. So in cheaper cars, if you get hit from the side, your head hits that side column. If you've got enough force, you're still going to go forward and hit things. The force of hitting an airbag at a high enough speed is going to cause your brain to hit something, your head to hit something. Don't forget the old favorite, the toolbox in the back seat of the car that comes flying forward, hits your head. So there's all sorts of different ways that we can do this and cause injury to the brain in a variety of different ways. But let's talk about the phrase that we're using here, which is mild traumatic brain injuries. I don't know about you guys, when I think mild, I think like salsa that tastes like ketchup, right? Mild, it's just not that bad. How bad could it be? It's a mild traumatic brain injury. And while I think that the traumatic brain injury part is a good change in the language we use to talk about these injuries, I think the choice of the use mild is unfortunate. Because if you're on the jury, you're like, well, it's just a mild traumatic brain injury. And if I'm defending a case, I would certainly want to emphasize the mild part. Well, doctor, come on, it's a mild traumatic brain injury, and you're going to elide the traumatic part of the brain injury. But the reason why we use the phrase or the word mild is because it differentiates brain injuries between brain injuries that are a result of anatomic damage, visible damage to the brain, as opposed to neuronal dysfunction, interruption of the electrical charges in the brain such that it stops working. Okay? So, brief review, neurons. Neurons are those nice little cells that send information, both chemical and electrical, through the brain. It is the wiring and pathways of our brain that causes us to be able to do things like think and communicate and understand information. Neuronal dysfunction is a disruption in those processes. And what happens is you get a jolt and things stop communicating with each other. And the hope is you put them back together and everything's going to flow the way it did. Mild traumatic brain injuries are the disruption. Anatomic damage is skull fractures, brain bleeds, swelling of the brain that causes damage on the outer edges. So that's why when we talk about mild, it's mild because the alternative is the really bad stuff, right? But it doesn't mean that mild traumatic brain injuries aren't serious and aren't an important thing that we need to be talking about when our clients get injured. So there's pictures of the neurons. They're going through and they're communicating with each other. And when we talk about an MTBI, it's the disruption of those pathways. And then the hope is that we put them back together. So in the context of car crashes, we want to talk a little bit about what does a mild traumatic brain injury look like in the context of automobile accidents. So most commonly what happens is there's an accident and the patient, the client, the plaintiff, depending on what role you're playing in all this, is transported to some medical facility for evaluation. There used to be in the literature a big emphasis on the Glasgow Coma Score, which for those of you who are familiar with that, it basically has to do with how conscious you are. You know, are your pupils reactive to light and the like? And that's sort of falling out of favor in the assessment of mild traumatic brain injuries because it's a great indication of how really bad off you are, but it doesn't tell us much about people who aren't to the point of losing the ability of their pupils to contract. So you're going to see some evaluations in emergency rooms immediately of the Glasgow Coma Score, also because the worse that score is, the more urgent certain actions are. But we're not really talking about those folks. We're talking about people with the classic mild traumatic brain injuries. So when you get to the hospital and they learn that there's a suspicion of a head injury, why is there a suspicion? Maybe you've got a big bruise on your forehead. Maybe the ambulance personnel report a loss of consciousness at the scene, or the police officer reports it, or the patient themselves reports it. What is most common is the person is sent for some sort of imaging. Most common is CT scan. It's fast, it's readily available. And the reason they're doing it is to look for that anatomic damage. Number one thing they're looking for is brain bleeds, because what happens when the brain bleeds is it starts pushing the parts of the brain that you would like to not be out of the way, and can cause damage and permanent damage to the brain if you let it keep going. If they see a brain bleed, then you're talking, depending on where you are, if you're more rural, probably a flight for life to a major trauma center for evacuation and removal. If you're in a larger city, they call in the neurologist who's going to go in and drill it out and let it drain and put in the shunts and all that good stuff. So that's the first thing they do. So they go, they put the patient in the CT scan, and they take a look, and they put up the films, and they do a wet read, and they say, looks fine to me. That tells you nothing about whether or not a person has a mild traumatic brain injury. And this is something I want you to take away with you. Mild traumatic brain injuries are typically associated with normal structural imaging, neuroimaging findings. In other words, that is what defines the NTBI. They don't show brain bleeds and skull fractures and the like. They show, on imaging, a normal looking brain. But we know that it's not a normal brain, but it shows up that way. So when you're looking at, and this is just a sample of what a nice, healthy, normal-looking brain looks like. We don't have any bleeding on there. There's no shifting of the midline and all those things that we look for in brains. Looks perfectly good. That's the brain of a person with a mild traumatic brain injury. It's also probably what everybody else's brain in this room looks like right now. So we've ruled out anatomic damage. We've done the CT scan. There's no brain bleed. Skull isn't fractured. We don't have bone chips in there, heaven forbid, and all the other bad things. Again, we still haven't gotten to what's really going on with this person. The symptoms of mild traumatic brain injury can be assessed in an emergency room, but they're not necessarily going to be assessed in an emergency room. Because frequently when you've got somebody who's severely injured enough that we're thinking that something's going on with the brain, they have other injuries going on at the same time. And emergency rooms are not places for deep contemplative thought on the psychological processes of patients, usually. They're just not able to do it. They can do some very superficial things. Do you know who you are? Do you know where you are? Do you know what day it is? We can do the mini mental stuff. But we're really not going to have a feel for what's going on with this person, also because the nursing staff there has no idea what this person was like 15 minutes before this crash. Are they smart? Are they slow? Did they always have a stutter? I mean, we don't know any of this stuff. So we got to think about the symptoms of mild traumatic brain injury as a continuum that starts in the emergency room but plays out over the next weeks and months. And I have a typo on my slide, for which I apologize. All right, so the symptoms of mild traumatic brain injury, we've got 4 categories: physical, cognitive, emotional, and sleep. And I want to talk a little bit about them all because it's important that we look at these really very holistically. Physical symptoms. Now, some of these physical symptoms you may see in the emergency room: headaches, nausea, vomiting, dizziness, balance problems. If you're looking, no matter whether you're defense or plaintiff, when you're looking at the emergency room records, are they giving them Zofran or something else for nausea? That's a clue. Why would they be nauseated? Car accidents don't actually cause nausea. It's usually an injury to the head that causes nausea. Sometimes it's a reaction to pain medications, but sometimes it's because we've done something to disrupt all the different things that need to go together in the brain. Balance, dizziness, visual problems, having a hard time seeing. Again, sometimes observable in the ER if you look closely. Fatigue. Now we get into some of the less obvious symptoms, things that aren't going to show up in the ER but are going to show up in the next days and weeks and months. Fatigue, sensitivity to light and noise, numbness and tingling, and a feeling of being dazed or stunned. Now, the problem with these sort of symptoms is they're symptoms of like 8,000 other things, right? And they're very hard to quantify. There isn't sort of a, well, if you feel this way, you're sensitive to light, but if you're that way, you're just, crabby. So these are sort of symptoms that are looked at, you have to look at as a whole. What is it that is different about how I looked at these symptoms previously and I'm looking at them now? So is it something where I every day would walk into my office and turn on my desk lamp, and all of a sudden when I go in and I'm just like, I don't want that lamp on anymore. That's sort of an indication of where you can see some of these symptoms. Now, the other problem with some of these is they're not testable. You can't run a blood work to see if you're actually dizzy. I can't do a test to see if you're fatigued. These are all self-reporting. And this is why it's important that your clients self-report, if you're representing the plaintiff, all of this constellation of symptoms if they have them, because one alone may or may not indicate something. But when we've got them coming together in a cohesive way, then what we're seeing is evidence that we're going to backdoor in an understanding of what happened to the brain. Cognitive symptoms. Again, these are really self-reporting and difficult symptoms. They're foggy. They just can't think as fast as they used to. Hard time finding words. They don't remember things the way they used to. All of a sudden, a spouse or a loved one will be like, God, I told him that 100 times. Now, the problem is any of us who have a spouse have told our spouses 100 times to do various things. This is different. And it's different, for example, as in, I told him to pick up our daughter at daycare and he forgot. All right? The sort of things that you really don't have to remind someone to do 100 times. Everyone knows the child needs to be picked up. If that happens once, it might just be a forgetful thing. If it's repetitive, then you've got something different going on. Repeating and answering questions really slowly. If you've ever interviewed a client with one of these, and they seem really smart, but you realize after a while it's like talking to a parrot, because they ask you the question back, you repeat it back, and then there's a pause, and then they answer. It's a symptom, again, of this disruption in the pathways of the brain. Emotional symptoms. Again, this is not going to show up in the emergency room. This is what shows up at home, at work, with other people. They become very, very crabby. They really can't tolerate certain things. And then not being able to tolerate the certain things makes the people around them angry. And you get in this very interesting loop where everyone's unhappy and they blame it on this person's mood. Sadness. They're emotional. Their emotions go up and down and up and down. You're crying at AT&T commercials again. It's that sort of thing, as well as inordinate fear and nervousness. Now again, everything I have just gone through with you is not testable. There's no blood test for it. There's none of that. But they are a constellation of symptoms that you'll see if you ask the right questions, come together and paint a picture of what happens in mild traumatic brain injury. This is always sort of my favorite thing. Sleeping too much or not enough are both symptoms. So what does that mean? Not being able to fall asleep, terrific insomnia, staying up till 3 a.m, but then also not being able to wake up the next day, or just needing to sleep all the time. Everyone's going to be a little different on this one, and if I were going to be attacking a doctor on this, I'd be all over this. I'm like, how can sleeping too much and not enough be both be a symptom of this? Has to do with how your brain is reprogramming itself and trying to recover from the insult. Now, another problem with everything I just went through with you is that these symptoms are all really similar to a whole variety of other problems. Post-traumatic stress disorder, depression, headache syndromes, malingering, a favorite word among some folks in the industry. So when we look at these different symptoms, we have to sort of keep in mind that if you're trying to show that someone has a mild traumatic brain injury, you have to sort of show the constellation of these symptoms and how they impact what's going on in their lives. These symptoms are not overnight. They take sometimes time, not always. Immediate symptoms sometimes you're going to see are the nausea, the headaches, vomiting, dizziness, stuff like that. You're going to see some of those more physical manifestations more likely right away. The other ones are subtle, and they take longer. And it's not necessarily, I think, always that the onset takes longer. The recognition that they are something out of the ordinary takes longer, right? So you go into the ER, you've been in a car accident, they give you a whole bunch of drugs because you hurt, right? Your back hurts, your neck hurts, you bumped your knee, and you've got this. Well, those pills are going to mask some of these symptoms for a while. Pain pills will mask an inability to sleep because they'll put you to sleep. Muscle relaxants will mask some of this stuff. So you've got to be aware also of when people start recognizing these symptoms frequently coincides with when some of the other physical injuries that they suffered in a car accident start to either improve or be handled. And they're left with these symptoms that we can no longer say that he's cranky because his foot hurts. She's not sleeping because her back is sore, all right? Now we're left with just they can't sleep. Or he's always angry. And it's no longer something that we can tie to the other injuries. So when you're looking for trying to show this injury, because there are all these amorphous sort of symptoms, we have to figure out what can we do to find evidence of a mild traumatic brain injury when no one's diagnosed it up front. So let's think about what happens in the emergency room and where you might find information. It's really interesting if you read nurses' triage notes. What is the nurse being told when this person comes into the room? What is the information that he or she is eliciting from the patient? What is the patient telling them? A lot of times, it'll say something like, patient does not recall if he or she lost consciousness. I'm pretty confident I have not lost consciousness this afternoon. And I've been in car accidents, and I know darn well that I didn't lose consciousness. The minute I see that I don't know if I lost consciousness or not, that's a red flag. Because really, that's something most people do know pretty strongly when they've been in car accidents, whether or not they lost consciousness or not. Same thing with I don't think so. Again, usually it's something that we can know. The next thing I remember, this is always to me a big red flag. There's a gap in memory between accident, I saw her coming and I felt the hit. The next thing I remember, the firefighters were trying to get me out of the car. Okay, probe that a little bit. Do you have any memory of what happened between when it hit and when the firefighters came? Do you remember seeing anyone? Do you remember talking to anyone? No. Do you have somebody on the scene, someone who came to help? You ask that person, you call that witness, and you say, witness, did you come and talk to Ms. Knuckles when she was in the car? Yep, I told her everything was okay, and I did all these things, and then the firefighters came, and I stepped back. Okay, that person had a big disruption in memory there. Apparently they were conscious, she was talking to her, but that memory has disappeared. That's a great indicator that something went on with the ability of the brain to form pathways and memories at that point in time. One I didn't put on the slide, but is happening more and more. They couldn't remember phone numbers to tell people, or they couldn't remember how to use their phones. I know that sounds like a weird one, but they're in a terrible accident. A Good Samaritan comes over and says, can I call someone for you? Yes, call my husband. What's his number? There's a disruption there. Because even though, I know none of us know any phone numbers anymore, we all know our home phone number. And we probably all know our significant other's phone number because we write it down a bunch of times. Or they can't remember how to work their phone. They'll say something like, I tried to use my phone, but I couldn't make it work. I couldn't remember my passcode. Again, it's sort of an indication that something's going wrong there. So after someone's in the emergency room, and they'll be diagnosed with a concussion, and they're sent home. And so now we got to talk about what do we do to treat a mild traumatic brain injury? What do we do about it? We've decided you've got one. The hospital says you have a mild traumatic brain injury, parentheses, formerly known as concussion. They'll send you home with 4 pages of information that you can't read because you just had a brain injury and aren't really processing that well. Here's what the current recommended treatment for a mild traumatic brain injury is. It's nothing. It's darkness. It's a room. It's absolute quiet and silence. Yeah, question.
Well, it's not a question, it's a statement. That's not really true. Physical therapy is being utilized now to mitigate the effects of concussions. My daughter basically is prominent in that area, has treated professional NHL players, professional football players. She lectures all over the North Shore of the Cook County to high school coaches, managers, treats high school players with concussions. And neurologists have referred their patients to her when they've had concussions. There is a set of treatments that physical therapists can utilize in order to mitigate the effects of a concussion and just basically cure many of the symptoms that you have just described.
That's an interesting perspective. I can tell you right now, the CDC's recommendation of an acute mild traumatic brain injury is quiet, sleep, no screens. I think I have this. No computer work, no reading, no multitasking, no sports and exercise, and no stimulation of the brain for a period of time after the event. Now, whether or not that then leads into physical therapy, I think that there's differing views on that, but in the acute, immediate onset of mild traumatic brain injuries, the recommendation right now is to rest the brain the same way if you sprained an ankle, you rest the ankle. And that there's especially an issue with regards to computer usages because almost every job everybody has requires screen usage, and the specific recommendation right now is no computer use in the first, anywhere from, I've seen from 24 or 48 hours to a week to 2 weeks after a mild traumatic brain injury to prevent that level of stimulation. No driving. No other sort of risky activities. Basically, the recommendation right now is that people go and make their brains very, very quiet. Now, every hospital that you go into, if you say you have a concussion, they'll frequently send you home with something saying, we want you to have a friend at home who's going to wake you up every 90 minutes, which some studies have shown is absolutely the worst possible thing you can do to this poor brain. It's overworked, it's trying to reconnect pathways, and now we're going to wake it up every 90 minutes. So there's some dispute on whether or not you actually have to wake the patient or whether you can just go in the room, make sure they're still with you, that they're still breathing and that they're still doing all this other stuff. The problem with the advice for this, which is sleep, rest, be in the dark, is who really wants to lie in bed in the dark and not do anything, especially nowadays. Like, you know, you're going to turn on the TV, you're going to stay home, watch a little Oprah. And this is sort of a hard regimen to enforce. Dim lights, dark as you can make it, resting the brain and letting it be. I am seeing some hospital discharge papers that start talking about that, but it's really sort of a hard prescription to give people as they're leaving with that diagnosis. So most people just don't do it. They shake it off, they work it off, they may take a day or two off of work to recover from whatever it is that they've been doing, also from whatever physical injuries they got from the accident itself. And so you're seeing people who are going to have longer residuals and time periods dealing with it. And the other thing too is there isn't necessarily a lot of good information being given to people as to what they're supposed to do in follow-up. You know, see your doctor if your symptoms don't improve. Well, you know, I'm getting better. I had a really horrible headache 3 weeks ago, and now I only have a mildly horrible headache. So when we talk about sort of trying to put together what does the traumatic brain injury look like in this individual, we got to talk about how it manifests itself down the road, because we're not coming into court 2 weeks after an accident, and we're not coming into court probably 2 years after an accident. By the time we're in front of either a mediator or a jury, we're talking about, and I'm not including adjusters, because unless it's a policy limit case, because you've got a $25,000 limit and I've got well over that, adjusters, to my experience, do a terrible job with brain injuries. They're just, it's not even worth it. I frequently don't even bother to do the demand. Let's just put it in suit, because I'm going to wind up there anyway. So let's talk a little bit about how we quantify for a jury, for a mediator, for arbitration or whatever, what this thing looks like. The gold standard is a neuropsych. There are doctors across the state who will do them for you. Neuropsychs, I think, are just fascinating documents when you've got a client with a brain injury. A neuropsychological evaluation is both physical and all of these different psychological tests. Your client will spend the day doing all of these different things. They'll do, the MMPI, and then they'll do word findings and number repetitions and all those things that you did in Psych 101 when you went to college and you got extra credit for. Your client's going to do them, and there's going to be a clinical evaluation, fine motor skills, gross motor skills, try to get an understanding of where this person's functioning is. The reason I think this is fascinating is what the tests are designed to do is to figure out where these people have deficits. Because the thing about mild traumatic brain injuries, they are not, generally speaking, global insults. Global insults meaning equal ways to all parts of the brain. Mild traumatic brain injuries are frequently very specific areas of damage. We had a disruption, and certain parts didn't connect back up the way we wanted them to. So we got to figure out where is it that those deficits exist, because these people will come to you, and if they haven't gotten a neuropsych, it's usually because they're still seeing a primary care doc or whatever, and they keep going in saying, I have headaches, and they're just sort of continuing that pattern. But they'll tell you, I feel like I can't find words anymore, or I feel like I can't do things fast enough anymore. And this is the way to quantify it. So this is a printout of a client. And this client was had graduate degrees, had been a professional at a bunch of different multinational corporations, and had a mild traumatic brain injury. So if you take a look at these scores, you're going to see that things like verbal comprehension, scoring pretty high, 75th percentile, that's good. And then take a look at this drop, though. Working memory and processing speed, it's like plummeting. That's unusual. For most of us in this room right now, our scores on our different parts of these tests are going to be within a band. They're going to go up and down, but they're still going to be within a band of sort of an average level of ability. Most of us have a level of ability within which we're going to bounce around a little bit. Chances are very good that we don't have any big divots in our scoring, because that's a pretty dramatic change in that. So when you've got somebody who's really well educated and really smart, who suddenly has these giant deficits, you can pretty much back out that it's unlikely that those existed previously. So how else can you show this stuff? When you've got clients like that one who has graduate degrees, go back and get their GRE tests. Because if this person's got word finding problems, but was scoring in the 90th percentile on the GREs and the vocabulary, we've got a disconnect, right? Processing speeds, mathematical abilities, you're going to find that on some of those standardized tests. And by the way, apparently they save them forever, because you can go back like 10, 15, 20 years and get those standardized tests and compare it to how your client functions now. It's not the best benchmark, but it's going to frequently be as close as you're going to get, because I'm guessing most of us in this room have not had an IQ test lately, haven't done an MMPI in ever, other than probably in college when you did it for extracurricular, or maybe you had to do it once or twice since. So we have to find these other ways of backing into how this affected your client. When we want to show the not MBTI. The injury, whether we want to show it to, again, mediators, judges, juries. The problem with them is, again, everything about them is hidden. Everything about what's going wrong is in the brain of the person, and there's no imaging that shows it. You're not going to be able to show a broken bone. The only image you're going to show is a perfectly healthy brain on a CT, right? That's the only image you got. Hey, look at this perfectly fine looking brain. So we have to talk about how do we show how it manifests itself. The injury is visible only by how it shows up. And the weirder the examples, the better. And I know that sounds like an odd thing to say, but to give juries an understanding, you can't just say, I have to give my husband more Post-it notes so he remembers to take out the garbage, because frankly, that's really not particularly impressive. But I had one client where the wife, it was the husband's job to take the son to daycare every day. And every day he could not remember to take the child's bag that had the diapers in it. And so the daycare kept, they fine you or whatever. So she started taking masking tape and at his eye level would tape across the doorway he had to walk through to get to the car and put a giant sign on it at night saying, don't forget the backpack. Okay? That's pretty extreme. I doubt most spouses in this room are doing something like that to convince their spouse or dear friend or loved one to take a bag with them. But that's what this family was reduced to, was literally forcing him to go through a physical barrier in order to leave so that he would remember that. It's interesting with really smart clients, if they're in their 40s and 50s and their career path is accelerating, it's sort of interesting, but a mild traumatic brain injury doesn't necessarily derail their career. It'll plateau it, it'll sort of flatten the curve. But frequently what people manage to do is they manage to figure out workarounds, or they go from being a rock star to being a reasonably competent employee. And so when you're trying to figure out future loss of earning capacity, it can be a real challenge, because defense counsel says, you're telling me your client has this horrible brain injury. He got a raise last year. He's actually making more money after this accident. It's true. So what do you do with that? Well, coworkers could be really good on that. And they'll be the ones who are going to fill you in and say, look, coworker used to be able to juggle turkeys and knives in the air while typing out letters to clients. Now he still is able to type the letters to clients, but all that other stuff he was doing that really made our group stellar, he can't do anymore. Or his secretary has taken on more duties and is covering for him. Or she used to be able to do these things. We rejiggered her title and her duties. Especially in small companies, people, they want to keep them. They like them. They're family. It'd be really bad to fire them after they got hurt. So they keep them on and they rejigger. They'll be honest with you about it. And then when you want to talk about loss of earning capacity, you can go to a vocational person and say, what is their ability to work outside of what has essentially been created in their own sheltered environment? Their friends and loved ones have created this sheltered work environment where they're going to stay, probably. But if new management came in, would they be reemployable in the same field given these limitations? Families. Again, what is the family doing to cover for, to adjust to the changes in the spouse? The saddest part of dealing with mild traumatic brain injuries is when you talk to the spouse and they will tell you, one of the symptoms that we talked about was irritability. Some folks just get kind of mean, and they didn't used to be mean people. And it's really hard for that spouse not to take it personally when they're like that, because of course when you're mean to someone you intend it personally, and yet it's also a manifestation of this brain injury. And so when you're talking to the family, and particularly to the spouse or boyfriend or loved one or fiance, whatever, it's interesting to sort of get a handle on that. Are they different? Do they treat you differently? Did they used to be nicer? Now, these are not questions you want to ask while your client's in the room, but it can be a real eye-opener on that. Again, workarounds, problem solving. What are they doing that's different? What is this person no longer doing in the house? Did they hire a lawn service because the noise of the lawnmower no longer makes it possible for the person to do that job? Who else is helping fill in? Is the mother-in-law now overwatching the kids because the noise of the children overwhelms her? And then when you are doing this, for heaven's sakes, don't have your client in there. Nobody's honest when the person is sitting right there. It's a good conversation to have with your client as follows. I am going to talk to your wife alone. I am going to strongly tell you that I strongly prefer that. I'm not going to share with you what she tells me. Now, you have a right to insist on it, but I want to let you know why. And that's because I need for her to be completely honest with me. And it's important that you not be here for that. When you're testifying in court, get them out of the courtroom. It's not fair to them, and the jury will also feel that the spouse has the ability to be a little more honest about it. It can be devastating to a marriage. It's a tough sell to a jury sometimes on that loss of society and companionship, because a lot of jurors say the following: hey, for better or for worse, baby, this is the worst part. Okay, how do we communicate that to the jury? And it's really to be able to say, I still love and support this person. They're just not quite the same person. The other thing is the impact on children. What's it like if dad's always angry? What's it like if mom can't stand to be around them because the noise and the cacophony of kids is now overwhelming? She sleeps all the time. She comes home from work and goes to sleep. It can be amazing if you've got a kid who's old enough, but still a kid, but old enough to be able to articulate what it's like now compared to what it was like then. Devastating testimony. It can be just amazing. You got to have a kid up to it, and that takes a certain amount of finesse. But boy, 12 and 13-year-olds are really sharp on seeing stuff sometimes, and they can really have a lot to say. So time keeps going, and there's that sort of rule of thumb: a year, where you're at in a year is about where you're going to be. I'm a big fan of not telling my clients that, because it just means that come a year they're just wiped. They're like, this is it, this is the most horrible thing. It was like what Kevin Martin said earlier today. It's a general sort of rule of thumb, and it has no applicability to an individual. Some people continue to improve. I've had clients who've had serial neuropsychs. One was at 1 year and one was at 2 years. There was improvement. So I try not to make them sad by telling them that. It's up to you on whether you want to, but generally speaking. So the long-term effects. They now have a brain injury. These are known long-term effects of mild traumatic brain injury: anxiousness, depression, concentration, organization. Your clients who have mild traumatic brain injuries who still are feeling rotten after a few months and aren't recovering need to go see someone other than their primary. Because these symptoms, especially anxiousness and depression, we don't want to get that to be their baseline. And they may need intervention and treatment and medications to at least manage those symptoms so we can work on the other symptoms that are part of their brain injury. But don't let them just languish and think they should be shaking this off. They need help. Now, what does the future of treatment of mild traumatic brain injuries look like? All right, so the one thing I want to share with you that I thought was really interesting is they are starting to do high-scale neuroimaging studies of brains of people with mild traumatic brain injuries. And what they've done is they've started to compare MRIs taken at the time of injury. They got injured, someone did an MRI. And then they're taking MRIs down the road of the brain. There's some early indications that there is actually brain shrinkage between those MRIs. Now, I'm not telling you that as authoritative or firm. I think it's a developing field. There isn't a conclusion on it. And I'm not convinced that if you don't have shrinkage, you don't have a mild traumatic brain injury. But that's some of the beginning. As imaging gets better, I think we may start to see more of that coming along. There is an absolutely terrific resource on the CDC's website on mild traumatic brain injuries. If you've got a case with it, it's about I don't know, 20, 25 pages, print it out, throw it in your research folder. It's a great resource. It'll help you understand a little better. And if you've got a client who's really having a hard time understanding their own symptoms, it's a great booklet to give to them if they are at a level of understanding of it. And it's the physician booklet that I think is really great and worth taking a look at, because it'll sort of go through a lot of what we talked about today. I have 1 minute. Any questions? Yeah. I'm sorry, time's up.
Which of the medical community do you get the best help from on the issues related to traumatic brain injury?
I get the best help from 2 resources, number one of which is a good actual therapist who will specialize in mild traumatic brain injury, because they will then be treating both the cognitive aspect and the depression and anxiety that I swear almost all of my clients have. And the second of which are the good neuropsychiatrists, because they're the ones who really get this stuff. The problem we have with, if someone goes in, like for example, I've had clients who did have like actual traumatic brain injuries. They go in and the neurologist does the evacuation and takes all the blood out, and the client goes back to the neurologist, right? This is a guy who specializes in the brain and the nervous system, and goes in and says, "Doc, I'm still feeling rotten." And the doctor puts up a film and says, "You're cured." Those are the worst doctors, because they're saying your structural problem is fixed, and it talks nothing about the insult that this brain has suffered and the repercussions that it has on the rest of their lives. So I'm a big fan of neuropsychs. I'm a far less big fan of neurologists. There are some that really get it, but I think a lot of them treat it the way orthopedists treat bones. Something to be fixed. Once I have fixed it, my work is done, and I think that does a real disservice.